Hi friends, Dr. Harsha here. Important concept about ureteric injuries from Vice Academy. So in this video we'll learn couple of things about ureteric injury and its management. So ureteric injury most common is iatrogenic and more so during hysterectomies and more so during laparoscopic hysterectomies. So there are certain areas where the ureteric injury is likely to happen. This happens actually when they are trying to control some kind of bleeding. So sometimes to control the bleeding or to arrest bleeding, they try to secure the internal iliac artery. So this is where it can happen. Or when transecting the vagina, this is the distal end of the ureter, it can be crushed or it can be transected while transecting the vagina. Sometimes what happens is while ligating the infundibulopelvic ligament, this is one of the more common areas where the ureteric injury can happen. So these injuries again can be a ligature injury or a cold injury with a scissor, or they can happen with a thermal injury when they are trying to arrest the bleeding with a ligashoe or harmonic. So depending upon the instrument also the management changes, because thermal injuries, as we know, have lateral spread, and the injury, though it appears to be small, the sequelae will be more when compared to the cold injuries. So how will ureteric injuries present? Most commonly identified in the post-operative period. So if you are the treatment funda, I will tell you, first presentation is if identified in the post-operative period, usually what happens, the patient gives a typical history that once the catheter is removed, she says that she is able to void normally, and also there is leak of urine from the vagina. So this is one catch point. If the patient says that there is continuous leak of urine from the vagina, that means you should suspect that it is a case of vesicovaginal fistula. There are situations sometimes what happens is there is a concomitant vesicovaginal fistula and also a ureterovaginal fistula. So what happens with the ureteric injury is the consequences are either of these two. One is it can form a UVF, a ureterovaginal fistula, or a ureteric stricture. So when there is a stricture, so this is again a catch point for you in the question. If there is a stricture, what happens is there will be hydronephrosis. So when there is hydronephrosis, there is probability that the unit will be lost, renal unit will be lost. So our goal is to put a nephrostomy and save the kidney. But if there is a fistula, so fistula means there is constant drainage of urine, so there won't be a gross hydronephrosis. So the chance of losing the kidney is comparatively less. Now coming to again what is the MCQ asked here is the timing of surgery. So either if you are identifying it intraoperatively, immediately try to repair it, or in the post-operative period, early post-op means within 1 week of the injury, then you can go inside and repair. But if it is going to be a delayed recognition of the ureteric injury, better to wait at least for 4 weeks by either placing a DJ stent or by placing a nephrostomy as the case requires. Why to wait for 4 weeks is the tissue is still friable, so suturing and all these things will be difficult. So better to wait for 4 weeks. But now again there are schools of thought who are advocating to do a early repair as early as possible, as and when it has been diagnosed. So this is about the timing of repair and what kind of surgery you need to do. So again it depends on the type of injury and also the size of the injury. If you can see the grading of ureteric injury, based on that you can decide, and also it depends on the level of injury. So in the question you have to look for certain catch points like the site of injury and also the type of injury and also the size of injury. So usually distal ureters, you cannot do a ureterostomy, so better is to go for a ureteroneocystostomy. So while doing a ureteroneocystostomy, sometimes it will be difficult for you to bring the have a tension free anastomosis. For that, what we do is we plan for a psoas hitch. So even then, if you are not able to have a tension free repair, then it is better to go for a Bowery flap, where the bladder itself is shaped into a flap, and ureteroneocystostomy is done. So this is about the distal ureter. So mid ureter, yeah, if the tissue is good and everything is fine, you can go for a ureterostomy, or again a Bowery flap can be done. So upper ureteric injuries are very difficult to handle. So upper ureteric injury, that means you have to bridge a defect of around at least 15 centimeters. So if the bladder capacity is good, then again you can try for a Bowery flap. If Bowery flap is not possible, then a ileal replacement of the ureter might be done, where a small segment of ileum is taken with its pedicle and anastomose to the renal pelvis, and also distally it is anastomose to the bladder. It's a difficult and challenging procedure, so one of the nightmares that can happen in urology. So this is about ureteric injuries. Whatever procedure that you are going to do, ultimately a stent is placed, and stent is usually removed after 4 to 6 weeks after the surgery. This is about ureteric injuries management. Thank you.